Our next talk, we have two speakers. We have Nikki Swarbrick. Nikki is a biomedical scientist with over 20 years experience working in transfusion labs. She's been with SHOT as the lab incident specialist since September 21. Previous to that, she was transfusion lab manager for many years. And during this time, she's implemented several new IT systems, including the new blood track systems and whole hospital electronic blood record systems, including the transfusion limbs. And quite a lengthy introduction there. Our second speaker I'll introduce at this point as well is Dr. Megan Rowley. Megan's a haematologist specialising in transfusion medicine. She was initially based in London, working at St Mary's and for the NHSBT, then moving up to Scotland in 2016, where she works for the Scottish National Blood Transfusion Service based in Edinburgh. Megan's always been interested in IT as it related to clinical and laboratory transfusion practice and has contributed to the BSH IT guidelines, as well as working with SHOT and on the SCRIPT initiative. Okay, over to you, Nikki. Thanks.
That's a great big title, isn't it? Thank you very much for inviting us. Yeah, so Megan and I are here to talk and take any questions you've got related to the IT aspects that reported to SHOT. So we're going to look through some case reviews and hopefully have an interactive session. So we've got some, if you've got your mobile phone available to you, that'd be really great because there's an interactive bit as well. Yeah, so to do regarding SHOT reportable incidents, so we look at every single report that comes into SHOT, we look at if IT was involved. So we would, and that's across the board. So we look at errors that were caused or contributed by IT systems, maybe where IT was available but it was used incorrectly. And we also look where errors, where there's an there could have been an implementation of a new IT system that would have prevented the error or could have prevented the error. And then we look at people's corrective and preventative actions, and we also include where if they've included an IT solution, we would class that in the IT chapter as well. Okay, so this is just a quick overview. This is last year's report. So when we look at the big chunks of categories, the SHOT reportable categories where it's the largest number of IT related errors, it's specific requirements not met and right blood, right patient. And I don't think it's probably not a surprise that specific requirements not met. So it tends to be either the lab aren't informed, so we don't update our IT system, or where the lab were informed and unfortunately those issues are overridden. And right blood, right patient tends to be related to patient identification errors, but we will come on to those as well. Okay, so we're going to look at some cases. Everybody likes a nice case. Maybe my answer to you would be have a think about the corrective and preventative actions. Could this happen in your organisation? And if it did, what would you do differently? And we also like to think about what worked well as well. So while we're looking through them, it's a self-reflection as well, if that's okay. Okay, so the first case was related to a wristband error. So we've got platelets required for a patient A. The wristband was faint, unfortunately, and in a proactive approach, the nurse decided to reprint it. So she goes to reprint it, she prints it from the printer, she picks up the wristband, but unfortunately she drops it on the floor. And in picking it up from the floor, she unfortunately picks someone else's up. She doesn't check the wristband against the patient again, she just attaches the new wristband, and thankfully in this instance the tracker did detect an error. So when the patient needed blood, the platelets, sorry, she scanned the wristband and the unit and the error was detected. So in this instance you can see that IT worked. It was used correctly, it detected the error and the error was rectified before the unit was given. When we think about incidents like this, which we do get a lot of, I suppose the weak points really are that a human has to attach the wristband to the right patient, and that really the IT in this instance, it should be the second checker rather than the first. The first checker really should be us humans and making sure that we're attaching it to the right patient. So there is a reliance really there on that a human's interaction is doing the right thing. Okay, so our second case is unfortunately about ABO, incompatible red cell transfusion. So a nurse collected 2 units at the same time. Obviously, that's not within their hospital policy, but they did, and there was a very high number of patients and they were understaffed. So to cut corners, unfortunately, they collected 2 units at the same time. Patient A, who was Group A, and patient B, who was Group B. She put both units on a trolley at the patient's bedside, and she used the electronic tracking system correctly. She scanned the patient and she scanned the unit, but when she turned around to the trolley, unfortunately, she then spiked the wrong unit and connected the other unit in error. So it was a B unit to an A. Thankfully, I noticed the issue immediately, so there was no reaction in the patient. But when we look at this error, obviously IT was used correctly. They did use an IT system at the bedside, but the administration relied on that human error. I suppose we have to ask ourselves, did that use of the IT lead to complacency and a little bit like the other ones? And obviously, again, the weak point is relying on that human, that they've checked, they've done the right processes up to that point where you're using IT, and then after that. But unfortunately, that didn't happen in this case. But the patient, they had no reaction. Okay, so this is the first VVox question. So between 2010 and 2021, so 11 years, how many red cell ABO incompatible transfusions do you think have been reported to SHOT? So we've got 0 to 100, so it's just a guess, have a go. Should have opened. And there we go. Mine is being really slow, so I don't know if everybody else is. Okay, so in the interest of time, I'll close that one off. Thank you for those who had a go. Wow, that's a massive spread. So that's fantastic. Thank you for having a go. The actual answer is 71 ABO red cell incompatible red cell transfusions have been reported to SHOT. So right over on the right hand side, and IT has obviously played a part in reducing that number. So, but unfortunately, as we can see, it also plays a part in and does have an impact as well. Okay, yeah, so correct answer 71. So this case is about cognitive bias. So we've got a patient A required a unit of red cells. They had 2 flags on the limb system in the lab. They needed K negative and they needed irradiated, and there were 2 flags. So unfortunately, the BMS is at the end of the day and they're rushing because they're trying to get used up some short dated stock, and we've all been there. So they've seen the multiple alerts, unfortunately become focused on the K negative, but they missed the irradiated flag and the irradiated requirement. Alerts did pop up, but unfortunately they were overridden and the unit was issued. Thankfully, the error was detected at the patient bedside, so there was no patient harm. But again, when we look at this incident, we've got alerts that are popping up, but they've been overridden. Is it because the alerts weren't clear enough? We don't know in this instance. Were the alerts, did they give an action for the BMS? Was there something for them that needed to be done? Were they easily overwritten? Some limbs you have a much more complex way of overriding than others. So some are just a simple escape key. So it's really making sure that if we have got alerts built in, that they are clear, that they're given action, and the alert has popped up, what is it you want me to do about it, and that they're not easily overridden. Thankfully, in this case, this was detected at the patient bedside, but unfortunately, SHOT do see an awful lot of reports where the lab issue incorrect units and an alert is overridden. So we will come to that when we go to the conclusions as well. Okay, so we've got IT alerts were used in this instance, but unfortunately they were unclear. So a patient A required a unit of platelets and ordered on the EPR, just like Julie's lovely system. So prior to admission of the patient, the clinical area update the patient's surname on the EPR system, but unfortunately that did not feed back into the limbs. There's no interoperability between the 2 systems for updating of patient details. So the platelets were issued with the incorrect patient details on, unfortunately, and they go off to the ward. The tracker that was used did detect the discrepancy between the wristband and the unit, but unfortunately the alert that popped up just wasn't clear enough for the nurse to understand what it was that they wanted them to do. So they tried 3 times to rescan that, they're thinking that they just, obviously the alert that popped up didn't give them an action. After the 3rd point, the nurse contacted the lab and they identified the error, and the unit went back to the lab and they were able to relabel that unit. But again, we're talking about, like Julie was talking about, that interoperability, so the 2 IT systems talking, so that reduces human error instantly because you've got the 2 systems and they will automatically update each other. And again, if we have got alerts, making sure that it's understandable for someone. If that alert popped up on me, have I had the training to understand what it means? And is it clear enough to give me an action from that? Again, I think there was a slight reliance on IT here, because really the primary action should have been the nurse check the wristband against the unit and error would have been detected. The IT really should be the secondary check. Okay, so this one is to do with a remote printer, and unfortunately it led to a delay in provision of red cells due to an issue with the printer. So the printer had run out of labels. So they've got a very lovely fancy electronic fridge that electronically issues units to them, and that's based in theatre. So the little printer that's associated with that fridge had run out of labels, and the theatre staff had never been trained on how to restock that printer. The printer was designed to count the number of labels that were used, but it wasn't configured to generate any alarms either locally or in the lab when it ran out. The access to the printer was just on a table next to the fridge, and every time, unfortunately, someone passed, they knocked the printer, and the printer paper was knocked out of alignment, and it meant that the little printer stopped counting. It didn't know it was about to run out. So unfortunately, in this case, it led to a delay in provision of units because obviously there was nobody in theatre who could rectify the issue, and the lab had to go and assist. There was, when we looked at the CAPA as well, there was no mention really of a contingency plan should there be any IT failure. So it was just making sure in this instance, obviously the IT was brilliant. This is what everybody would hopefully aim to have, these lovely fridges, but making sure that if you are implementing this sort of IT, that it's in the right location. You've considered the training of all the staff who are involved who will be dealing with it, and that it's just configured correctly. And in this case, like it says at the bottom, there wasn't really a mention of a contingency plan in the shop report, and there were no emergency units available in the fridge. So it's just making sure, obviously, if you've got an IT system in place, that there will always be a contingency plan should it fail, and that contingency plan, there's been a practice of that as well. Tracker downtime. I think we're okay for time. I'll keep going. I know we might be a bit over. So patient A was transfused with red blood cells intended for patient B. So the nurse collected the unit correctly, but at the bedside, unfortunately, the tracker lost power during the check-in stages, which is obviously the worst time for that to happen. There was a downtime procedure, but the nurse didn't follow it and continued to check the unit on their own. They didn't ask for a second checker to come and help. And then fortunately, the next shift nurse noticed that the wrong patient's details were hanging on the unit of blood that had already, the administration was ongoing. Fortuitously, in this instance, both patients were O-pos and neither had any red cell antibodies. So I suppose a lucky escape in this instance. Unfortunately, I think there was IT was available, but it wasn't used correctly. So it's just making and so like over reliance on IT as well. And making sure that, again, we've talked about having a downtime procedure, and if you've got one, that people know where it is and they know how to follow it. And it's really important to if you've got IT equipment, to look after it. This one lost its power during the process, but you would hope that they've got part of their policy is ensuring that there's a backup plan or a plan B. And I suppose following on from all of those is that don't assume IT will solve all of your problems. IT will solve a lot of the problems, but it will create some of its own as well in addition. Okay, so this question is related to the last couple of cases, and it's just really from your organisation. So do you have a clearly defined process for periods of IT downtime? So it's simple, yes for all of our IT systems, yes for some, or no. Thank you for everybody taking part. So I'll close that one now because I'm again conscious of time. Yeah, I think it's really hard, isn't it? I would hope that the people in the know section can go back to their organisations and look at the potentials for IT downtime. No system is ever infallible, as there will unfortunately always have, and as often things you've never considered as well, but making sure that you've got a process and that staff are trained in it and they are aware of how to and where the policy is. Okay, so we're nearly at the end, so we've got a couple more cases left. This one is about a HSCT patient, so a stem cell transplant patient. So they are admitted and grouped as an AB positive. The patient advised the clinical team that they'd received a transplant 6 months prior, and the primary treating hospital was contacted, who informed them that the patient now required BPOS and irradiated red cells and components. So the LIMS note was added to reflect this requirement. So just a note. And then the next request, unfortunately, the BMS issued two B neg and one A neg red cells. And unfortunately, in this instance, the ward didn't detect the ABO incompatibility either. So this again leads us back to that interoperability. Is there a potential that the two systems could talk to each other? Not always possible, but it might be something to plan for the future. In this instance, the use of a notepad rather than using any algorithms or logic rules. The alert wasn't set up, and unfortunately it required manual interpretation, the notepad, and in this instance, unfortunately, the BMS has made the wrong decision. So related to that patient group, so between the last 10 years, 2010 and 2020, how many hematopoietic stem cell transplant patients have been transfused with wrong components? So we've got 0 to 300 and something, haven't we? So have a guess. How many do you think might have received units that were not appropriate? Right, I'll press it off. Oh, a huge range. Yeah, unfortunately, the answer is enormous. It's 277 patients, so it's right over on the right-hand side. So these are quite complex patients, often have a primary and secondary hospital, so they might be shared care, and often the labs and the clinical teams in different areas aren't informed at the appropriate time. And sometimes, unfortunately, when they do, the lab either the limb systems isn't capable of dealing with such complex patients, or as a reliance on in this instance putting that complex requirement into the notepad, which obviously requires a human to read that, and there's potential for error there. So yeah, it's the shot. Why am I not moving? Oh, there we go. There is some learning on the shop website. There's an awful lot of learning on the shop website. There's lots of information out there, but this one in particular talks about major and minor ABO incompatibilities for these patients. If you needed to expand your SOPs or policies, if you don't get many of this patient group. Okay, so this is our last case. We've got a hemoglobinopathy patient. It's not necessarily related to the hemoglobinopathy. It's more to do with IT. So it could be any patient group, really. So a sickle patient required a red cell transfusion, and unfortunately, the units given didn't meet any of their specific requirements. They weren't RH or CAL matched, HBS neg, or fresh red cells. A LIMS alert had been added But this hospital had multiple levels of alerts that they could add, and unfortunately was added at the wrong level. It was added at level 1, so it meant that only the transfusion lab manager could see that alert. So unfortunately, in this instance, standard red cells were issued. Thankfully, the patient did not develop red cell antibodies on this occasion, but so IT in this instance was used, but unfortunately just not correctly, and it's just making sure that you configure your LIMS correctly. LIMS are really clever, aren't they? But it must be set up to the right level and making sure that the right patient groups receive the right, based on your local requirements, receive the right blood components. Okay, last question, I promise. In the same patient, in the same time frame, how many hemoglobinopathy patients received red cells that didn't meet their specific requirements? So here we've gone from a 0 to 150. So have a go. Yeah, so everyone's over on the right-hand side, which is so that's great. Yeah, unfortunately, there were 127 patients, hemoglobinopathy patients, that didn't meet their specific requirements. But these are complex patients, aren't they, with complex needs, and it's really important to make sure that they receive their specific requirements. We certainly see into the hemolytic transfusion reactions, what happens to patients when they don't meet those requirements. So these are really important to meet theirs. Okay, so quick summary. I know I'm conscious of time, so IT can be really helpful, absolutely fantastic. From starting in 2000 to now, IT has massively changed the way labs work, absolutely for the better. But when you're setting them up, you must set them up correctly. It can introduce new errors both in the clinical area and in the lab area. So when we look at those alerts, we talk about alert fatigue. So there's too many alerts, you just can't see the wood for the trees. Cognitive bias, again, you are making assumptions based on what you think it's going to ask you to do, and then over reliance on IT. That obviously the IT is there to pick up that error, but ideally we would have detected that as humans, we would have seen the error before we've got to that point. So sorry, it keeps jumping. So LIMS need to be set up appropriately. Alerts must be understandable and actionable. We saw in the cases where they weren't and the staff weren't sure what to do. Ideally, you'd want interoperability between IT systems. If the two systems can talk to each other, then it certainly improves patient safety. And having a contingency plan for any downtime at all is obviously the way to forward. And there's loads of resources in the shop website. So small plug from our perspective, shop bites and webinars and all sorts of things. So please do have a little look on there. And I know you're not asking any questions here, are we? We're going to ask them at the end, but so that's our presentation. So thank you for listening.